Hello and good evening, everyone. So how are you all doing? So finally, the NEET MDS 2025 exam is over. And how was it for you? Please do use your comment box and tell me whether it was like very easy for you or moderately easy or moderately difficult or very difficult for you guys. How was it for you? We were also collecting feedbacks from our students, and most of them had responded saying that it was kind of like moderately difficult. Okay, like it contains both of like uh, easy question and some challenging questions. Okay, so I hope it was the same for you guys also. And if you want to use the chat box, you can use the chat box to interact with me. Okay. Okay. So if you look at the NEET MDS 2025 exam paper, you can see that since it was the first time for the introduction of time-bound section, like some students really faced issues in the time management. So some students really struggled to finish the part A questions. Okay, part A contains like 100 questions within with that you have to like attend within 75 minutes. Okay, so some students really struggled to finish these 100 questions within the given 75 minutes. So there was time management issues for some students. And the general opinion that they told is that most of the questions, that is around like 40 to 55 50% of the questions that appeared in the NEET MDS examination, it was of like it all started with the same phrase, like a child patient reported to the clinic, or a 8-year-old child patient came to the clinic, or a 3-year-old child patient with his parents came to the clinic, or a 1-day-old child patient came with the parents, or like a 29-year-old male patient reported to the clinic, and a 60-year-old female patient reported with a vesicular lesion. Like if you look at the pattern of the questions that appeared in the NEET MDS 2025 examination, most were like clinical based or clinical oriented questions only. Okay, so that highlights the importance of solving more and more clinical based or clinical oriented questions. And it also emphasizes the fact that there's no need in like mugging up the facts. You need to understand the concepts properly, and you should know where to put it in a practical manner also. Okay, so that's very important. These points are for the ones who are going to attend the exam next year, mainly the NEET MDS 2026 exam. For the ones who had completed the exam, it's done and dusted. Then another thing that is like very prominent is the as I had already mentioned, the one is the time management issues, and the second one is this clinical based questions. Okay, there were image based questions also, but comparatively less when compared to the NEET MDS 2024, compared to the previous year. It was less this time. Okay, but there were image based questions also, and there were like factual questions also, direct straightforward one liner questions were also there. Okay, so in today's live session, we'll be mainly focusing on the questions that had appeared for the NEET MDS 2025 examinations in the oral pathology and oral medicine subject. Okay, so we'll be mainly focusing on these two subjects only today, oral pathology and oral medicine questions. We will discuss it today. Okay, so before going into the session, let me introduce myself. I'm Dr. Nivedita Tampan. I'm an oral pathologist and co-academic director of Edento. Okay, so from oral pathology and oral medicine. Okay, oral medicine means I'm not including the radiology part completely. No, the radiographic interpretation of some pathologies I have included in the session. But other than that, the pure radiology part, the radiation physics and all those parts, and the extraoral radiography, there were questions from extraoral radiography and all, I have not included in this session, because in today's session, we'll be discussing mainly oral pathology, oral medicine related questions, and some of the radiographic interpretation of the some pathologies. Okay, because there will be like image based questions in from the x-rays, but not purely radiological part. We are not discussing it now. That will be discussed by an oral radiology faculty separately. Okay, so around 25 to 27 questions we were able to recall, and most of these questions were like clinical based questions. Okay, so out of these 25 to 27 questions, around 19 to 21 questions are of purely clinical oriented questions only, like the ones that I had already mentioned, whether the which started like a patient came with this problem, or a child patient came with this problem, or a 60-year-old female patient came with this problem. Such clinical oriented questions were mostly there. Then there were image based questions also. We were able to collect like 4 image based questions, and like direct straightforward factual questions were also there. Around like 6 factual questions were also there. So if you look at the difficulty level of these questions, it is comparatively like moderate to high difficulty level questions. And the topics, okay, let's have a look at the topics from where the which is like the favorite of examiners. Okay, so the examiners really like the topic of developmental disturbances of tooth. Nearly like 3 questions were there from the developmental disturbances of teeth alone, and the next favorite question was the syndromes, related to syndromes. Okay, nearly like 3 to 4 questions were there completely related to syndromes alone. Okay, so all the syndrome related questions also I had included today. Then cyst, definitely 2 questions were there. Potentially malignant oral disorders, salivary gland disorders, skin disorders, bone pathology are all like favorite topics of the examiners. It all had like 2 questions each, which we'll be discussing in this session. And then tumors, oral manifestation of systemic disease, chemical injuries, periapical disease, and benign and malignant tumors were also there. Okay, there were questions from infections and hematological disorders also. There was a question like an HIV patient came with one side of the face having like necrosis in the face, and sample was taken, and in the sample like broad accepted hyphae was seen. What is the diagnosis? Like that a question was there. And hematological disorders also. A child patient came with swelling in the neck region, which is like a recurrent swelling. So hemophilia A was one of the option in that question. So it can be like overlapping with microbiology and general pathology. So we had included such questions in general path and microbiology. But other than that, if you look at just the oral pathology and oral medicine alone, like around 25 to 27 questions were asked, which we will discuss most of the questions today. Okay. So coming to question number 1, a patient with kidney disorder complains of white patches on the tongue and mucosa. His blood examination showed the following values. The values I had not mentioned it here because I didn't clearly remember it, but the values contain creatinine level values. Okay, and the creatinine level values were like really high. The creatinine level values were really high, indicating a kidney dysfunction. Okay, so those values were given, and this lesion subsided after hemodialysis. What is the diagnosis? Yes. So this was a question, and the answer is simple, straightforward. It is uremic stomatitis. Okay, so this uremic stomatitis, we had already discussed it in our previous sessions, whether for the regular batch and for the TND batch, we had discussed it. So this uremic stomatitis is nothing but it is an uncommon complication of the renal failure. In case of like acute or chronic renal failure, what happens is that the urea and the nitrogenous levels will be increased in bloodstream, and it will be increased in saliva also. So there will be urea getting secreted in the saliva. Now there are like normal commensals of bacteria that is present in our oral cavity. This bacteria secretes the enzyme urease. So this urea will be broken down with the help of this urease enzyme secreted by our normal bacteria flora, which will result in the liberation of ammonia. Okay, so because this ammonia is getting released, this ammonia will go and damage our oral cavity parts, leading to whitish patch or whitish plaques. which looks just like leukoplakia. Okay, leading to leukoplakia-like lesions in the oral cavity. Most common in the buccal mucosa, tongue, and in the floor of the mouth. Okay, it will cause, there will be a little bit of burning sensation and all will be there. Okay, so this is something that we had already discussed in our classes. So the same question was asked for the NEET exam also. The next question is an image-based question, which like I think it appeared in part A section. A HIV patient came with white unscrapable lesion on the lateral border of the tongue as shown in the image below. Which of the following is a causative organism? The image that they had given was not as clear like this. It was a little bit blurred image like this. Blurred image, but it is easy to make out that the patient is suffering from oral hairy leukoplakia. Okay, so what is the causative organism for oral hairy leukoplakia? It is option B, Epstein-Barr virus. Now, when they talked about like HIV patient, okay, so for an HIV patient, the most common organism or the most common diseases that is like strongly associated with an HIV patient include candidiasis also. But do not get confused with candidiasis because this is like specifically given in the image like it is like a white unscrapable lesion. Okay, so it is a white unscrapable lesion and it produces like vertical streaks like this. Okay, you can see from it vertical streaks like white lesion is present here on the lateral border of the tongue. Okay, so that is characteristic of oral hairy leukoplakia and it is caused due to Epstein-Barr virus. Okay, now if you look at the Instagram page of Idento, I had done a reel, okay, describing about the causes and the features that are seen in the oral hairy leukoplakia. You can check it out in this link. And it is one of these, oral hairy leukoplakia is one of the most common Epstein-Barr virus related lesion in patient with AIDS. Okay, so the answer is Epstein-Barr virus. Now, this is a very interesting question that they had asked. A 3-year-old child patient reported with his parent showing profuse salivation, torn out patches of hair, sweating, premature loss of deciduous teeth, and maculopapular rash. What is the diagnosis? Yes, doctors, if you know the answer to this question, you can comment below on this video. Okay. So is it due to arsenic toxicity or is it due to mercury toxicity or is it due to fluoride toxicity? Then option D was some other toxicity, which I don't remember. That's why I had not included it. Since I'm not sure, I had not included it. But what do you think is the answer for this question? Okay. And I think like most of them had answered this question as option A, arsenic toxicity. But the answer is mercury toxicity. Okay, the symptoms they had mentioned in this question, profuse salivation, the signs and symptoms they had mentioned in this question, the profuse salivation, torn out patches of hair, sweating, and premature loss of deciduous teeth with rash, maculopapular rash are all features of, yes, you can. Please remember, yes, these are all features of pink disease, or which is also called as swift fear disease, or which is also called as acrodynia. Okay, if you look at the oral pathology Neville and Allen textbook, you can see that the words they had used in the question was actually given in the textbook also. A pruritic rash, a maculopapular rash will be there, sweating will be there, lacrimation, increased lacrimation will be there, and torn out patches of hair, premature loss of teeth. All these are symptoms of chronic mercury exposure in infants and children. Okay, because of the mercury toxicity only, these children are getting this acrodynia or pink disease or swift fear disease. Okay, so all the features that they had shown here are features of this pink disease only. Okay, so this pink disease is usually characterized by why it is called as pink disease, because like red, painful, desquamating fingers will be seen in the children like this. Their fingers and toes will be like reddish or pinkish in color, and then there will be neurological symptoms and hypertension can also be seen. Okay. So this pink disease was really common in the early 20th century. Okay, especially in European countries, it was very common in the European countries in the early 20th century. So the physicians were like confused, like how a infant or a child is getting exposed to such high levels of mercury. Okay, so they conducted a research and they investigated about it, and they found out that it was this mercury toxicity for these children was from teething powders. Okay, so what do you mean by teething powders? Teething, what do you mean by teething? Teething means when the first tooth erupts into the oral cavity of a child by around like 4 to 7 months of age, what happens is that the child will show some kind of irritation. Okay, some children will have fever, a mild fever. Some children will have like increased salivation. Generally the child will be like irritated during the teething time. Okay, so to reduce this teething irritations and to reduce this teething symptoms, there were commercially available teething powders available. Okay, so the teething powders were available commercially. So a particular brand of teething powder was used by so many parents, and later on it was found that these children suffer from this acrodynia or this pink disease. Okay, so when they investigated it further only, they came to know that these teething powders contain mercury, which is making the children susceptible to this pink susceptible for this mercury toxicity. Okay, so that completely banned this teething powder. Okay, so remember the answer for this question was actually mercury toxicity in children. The chronic mercury exposure in infants and children, it is known as like acrodynia or pink disease, and all the features that they had given in the question were there in the textbook also. You can refer it in the naval and allied textbook. So the main cause for this mercury exposure is because of this teething powder. Okay, so I hope you are clear about it. Now, next question. A female patient reported with multiple painful ulcers in oral cavity, vagina, and conjunctival mucosa. On examination, the patient was found to show positive antibodies for HLA-B51. What is the diagnosis? Okay, so there were ulcers in the oral cavity, vagina, and conjunctival mucosa. And the key point here is the positive antibodies for HLA-B51. Okay. So out of all the syndromes that are given here, Sweet syndrome can produce ulcer-like lesions in the skin. Magic syndrome, definitely it produces oral ulcers, mouth and genital ulcers. Okay, that is the full form of this magic syndrome, I'll tell you. This mouth and genital ulcers will be there in the magic syndrome also. Behcet syndrome also, there will be like oral and vaginal and conjunctival ulcers can be there. Okay, so the key point here to differentiate between the syndromes is this positive antibodies for HLA-B51. Now that is shown only by option A, Behcet syndrome. Okay, so yes, it is Behcet syndrome. We have a NEET MDS group where we'll be discussing daily such clinical oriented or clinical based questions in our Idento group. So we had already discussed this question in our WhatsApp group also. So as you can see, oral ulceration with genital ulceration, eye and skin lesions are all features of Behcet syndrome. And the test that is used to check this Behcet syndrome is the pathology test. And the patient will be usually positive for HLA-B51 and histocompatibility will be shown. Now, like I had already mentioned, the magic syndrome, it also shows mouth and genital ulcers. The magic, it is like a, for the full form of this magic is this mouth and genital ulcers with inflamed cartilage syndrome. Okay, so it also shows mouth and genital ulcers, but the positive antibodies for HLA-B51 will be shown only for this Behcet disease. Okay, Sweet syndrome, it is a form of acute febrile neutrophilic dermatosis. Okay. Now, next question. A patient reported with vesiculobullous lesion clinically. Okay. On histological examination, intraepithelial split is seen between keratinocytes and round cells. keratinocytes, and round cells with nucleus also seen inside the split. What is the diagnosis? Okay, so the key point here in this question is intraepithelial split. Okay, so the intraepithelial split is shown among this option. It is shown for pemphigus only. Others are bullous lesions which show subepithelial split. Okay, so this intraepithelial split is shown for pemphigus only. Yes, doctors. So in between the keratinocytes, there are like specialized structures which are called as desmoglein 1 and 3. We had already discussed it in our classes. So this desmoglein 1 and 3 is involved in this pemphigus, which will get destroyed because of the antibodies, and it will result in a vesicle formation, which will like easily rupture and form ulcerations like this in the oral cavity. And pemphigus also shows positive Nikolsky sign. So we had discussed all about the pemphigus vulgaris in our class, and they had mentioned especially like round cells with nucleus inside them. Yes, they were mentioning about this Zang cell or acantholytic cells only they were mentioning. Okay, so in the NEET MDS 2024 paper also there was a question on pemphigus. Pemphigus is like a favorite topic of examiner. So there was a question in the 2024 exam also, but in the 24 exam they had made it more difficult by asking about the immunofluorescence, like where will you see like chicken wire pattern of immunofluorescent and all. But this time I think they had made it more easier. Okay, just the histopathology is mentioned. Then next, another question, say a similar question from the skin disorders. A 60-year-old female patient reported with ulcerations on eyes, oral cavity, vaginal mucosa, and adhesion between upper and lower eyelids. Okay, this is the key point. Adhesion between upper and lower eyelids. And on histopathological examination, split is seen between the epithelium and the connective tissue. What is the diagnosis? Yes. Yes. The ulcerations are seen in almost every mucous membrane that is present in the body, and it indicates a split that is in the subepithelial region. Okay, so we can choose mucous membrane pemphigoid. Yes, in the mucous membrane pemphigoid, you will be able to see it is also called a cicatricial pemphigoid. Why? Because it forms scar areas. Okay, so there will be bullae like this will be seen in the skin, which will rupture, and there will be like the area where the bullae rupture, it will form like erosions like this. And in the eye region, okay, the eye region is like the main importance in the cicatricial pemphigoid, because in the what they had mentioned in this thing is the adhesion between upper and lower eyelids. Okay, so what they are trying to mention is something called as symblepharon. Okay, so what is the symblepharon means? Due to these ulcerations, there will be like fibrosis happening in the eyelids, and it can get inflamed and erosion can be there, and it will attempt to heal, which will result in scarring in the bulbar and conjunctival mucosa. So this will result in something called as symblepharons. Okay, symblepharons means there will be adhesion between this bulbar and palpebral conjunctiva like this, and which can again progress to entropion. That is like the eyelashes of the lower eyelid can get directed inwards. Okay, that will result in constant irritation for the eyes. Like that, entropion and trichiasis can be there. Okay, so the one point that they are trying to mention in the question is about this symblepharons other than the ulcers, and also like the this thing is given properly given, the it's a subepithelial cleft. Okay, so the answer was mucous membrane pemphigoid. The next question, a routine radiographic examination in a 16-year-old female patient for unerupted canine shows unilocular radiolucency. Histological examination shows the image given below. What is the probable diagnosis? Okay, so identifying a pathology just by a histopathological image, just by the help of a histopathological image, will be a little bit challenging for a BDS graduate. But for the past 2 years, I think in the NEET MDS 2024 examination also, they had given an odontogenic cyst histopathological image, which is the glandular odontogenic cyst histopathological image, and ask you to identify it. Now, this time also, they had given a histopathological image. And if you look at the image, I cannot get the image completely, but I will tell you the findings that I found in the image. There were nodules like this. Okay, you see this nodules like this in the center? Yes, there were nodules like this. Lots of nodules like this were there in the histopathological image. And uh, just like how a stream goes around a rock, okay, like that, streaming fascicles of spindle-shaped cells were there surrounding this nodule. Okay, that was like clearly given in the picture, like streaming fascicles of spindle-shaped cells like this. Okay, these kind of streaming fascicles. Okay, that was like clearly given in the image. Okay, so such streaming fascicles of spindle-shaped cells. Okay, they were formed by spindle-shaped cells. So duct-like features and rosettes were not that clear in the image that was given for the exam. It was not that clear. But one thing that I noticed was these nodules were there and streaming fascicles of this spindle-shaped cells were there. And at the down, there was something called like a dark pink colored irregular structures were there. Okay, so these kind like dark pink colored irregular structures. Okay, so they resemble something like calcification. Okay, so when you see calcifications in an image, okay, it is easy to identify actually the calcifications because they will be appearing like pink colored structures, very irregular in structure, and they are there at the like in the image below. Okay, so it will be very easy to identify such calcified structure. So when the first thing that you will notice might be the calcified structure. So you can be prompted to choose the option D, which is calcifying epithelial or odontogenic tumor. But actually, it is not option D. It is option A, adenomatoid odontogenic tumor only. Okay, so let's have a look at the clinical features that is given here also. Okay, 16-year-old young patient, female patient with lesion in the maxillary anterior region and completely asymptomatic. Okay, they had like identified this lesion just because of a routine radiograph only. Okay, so completely asymptomatic, no pain, nothing. Okay, no swelling, nothing. Okay, so that points towards adenomatoid or odontogenic tumor. And when you look at the image for confirmation, it confirms because such nodules like this with streaming fascicles of spindle-shaped cells are also seen. These calcifications are nothing, but they are a result of abortive enamel formation. Okay, in AOT, you will be seeing calcifications like this because of abortive enamel formation. There was an attempt to form enamel, but it was aborted. Okay, because of the tumorous changes, it was aborted. So it will appear as such calcifications inside the tumor. Okay, so AOT was like frequently discussed by us, the two-third tumor. Why two-third tumor? Because two-third of it occur in the young patient, two-third in the anterior maxilla, and two-third affects the females. Okay, that was the two-third tumor. And rosette-like structures. Okay, rosette-like structures were commonly discussed. hyaline rings, calcifications, and the tubular or duct-like structures. But the tubular or duct-like structures were not there. Only these nodular areas with streaming fascicles was there. Okay, commonly discussed question among the NEET MDS aspirants. Okay, so the next question is 29-year-old patient presented with radiolucencies in the posterior mandibular region as shown in the image below. Intraoral examination showed less expansion in the lingual region. What is the probable diagnosis? So this is this I think it was an OPG image that was given. And the lesion was like really big. Okay, almost covering the angle and the ramus of the mandible, like really big, and multilocular radiolucencies were seen inside. Okay, and some of the posterior teeth were actually missing. There was no 8 and no 7. I think only 6 was also, only from 6 it was there. And so what can be the diagnosis? Yes, it is odontogenic keratocyst. Okay, so the key point in the question is showed less expansion in the lingual region. Okay, so radiographically, if you look at it, the lesion is like really big. Okay, so clinically, the lesion should be really big too, right? But they were telling that the clinically it showed very less expansion in the lingual region. Okay, so that points out the fact that this cyst, okay, some cyst, okay, whether it be like dentigenesis cyst or some kind of cyst, it is growing in an antero-posterior direction. Antero-posterior direction, not in buccolingual direction. So since it is like growing in an antero-posterior direction, that's why it is causing less expansion of the buccal and lingual cortical plates. Okay, so that's why clinically only very small swelling is seen. Once it reaches like a really big lesion only, then only it will show like some kind of swelling in the buccal or lingual region. Okay, see is another frequently discussed question among us. Okay, we had discussed I think in the fast track TND program and in for the regular batch also. Okay, so the all the picket fence appearance and the anteroposterior growth pattern and what is the features that differentiates OKC from the other cysts were all discussed. Okay. Now, next question. A child patient reported with parents complaining of missing teeth. On oral examination, a big tooth is seen with overall tooth count less than the normal number, as shown in the image below. Radiographic examination showed single pulp chamber and 2 root canals. What is the diagnosis? Yes, doctors, any answers? Is it due to macrodontia or gemination or fusion? Okay, gemination and fusion. I think this time they had asked 2 questions that are like interrelated with the same options like fusion and gemination. Okay, so that can make it a little bit confusing. One was an image-based question like this. The other question we'll discuss it next. Okay, so I think it was similar to this. Okay, 7.2 and 7.3. Their big tooth was present, and the total tooth count, if you look at it, it was less in number. Okay, so that is the key point in this question here. The overall tooth count is less than the normal number. So when the overall tooth count is less than the normal number, it is due to result of fusion. Okay, difference between fusion and gemination is like already discussed in our classes. So gemination means it is the attempt of a single tooth bud to divide, whereas fusion means it is the union of two normally separated tooth buds. Okay, so usually the tooth count will be the same in gemination, whereas it will be less than 1, less in case of fusion. Okay, so that since it is like specifically mentioned that the tooth count is less, then we are going with the option D. It is due to fusion of 7.2 and 7.3. Okay, and usually in fusion, you'll be able to see single root and root canal. Whereas in gemination, you'll be able, usually in fusion, you will be able to see separate root canals like this. Whereas in gemination, it will be usually single root and root canal. And it is more common in mandible also. Fusion is more common in mandible also. Since in the picture also, it was a mandibular tooth was given, then we can opt for fusion. Okay. So this was the question that we had already discussed in for our fast track revision program and all. And now this question was a little bit confusing because let's see, a child patient reported with a big tooth in oral cavity. Radiographic examination revealed 2 roots and 2 root canals. What is the diagnosis? Okay, it was a big tooth and the radiographic examination revealed 2 roots and root canals. Okay, they had not mentioned about the tooth number here, and they had not specifically mentioned about whether the crown of the tooth is like single or nothing like that was given. Just the only thing they had mentioned was like 2 roots and 2 root canals. So we are going off with fusion because only in fusion it shows like 2 roots and root canals like this. Gemination, it will be usually a single root and root canal like this. It will be usually seen. Okay, so we are going with fusion here. Okay, if you know any more details to this question, then please comment below in this video. Okay, it will be really helpful. Then we will choose the answer accordingly. So if you know any more details of this question, please comment below this video. Okay. Now next is identify the lesion which shows highest malignant potential among the following. Is it erythroplakia or OSMF or leukoplakia or lichen planus? A straightforward question. In the NEET MDS 2024 exam also there was a similar question, but it was a clinical oriented question and more twisted. Okay, it was an interesting question. Like 3 patients came to the clinic. One has a white lesion, one has a red lesion, and another one has a mixed red and white lesion. So which of this patient will be at the risk for highest malignancy potential? Okay, that was the question in the NEET MDS 2024 examination. Okay, but this time they had made it like really simple. Okay, like straightforward, they were asking like which of these lesions shows highest malignancy rate. Okay, remember this table always. In case of the malignant transformation potential, always remember this table. The highest one will be definitely proliferative verrucous leukoplakia. It has the highest malignant potential. The next one will be reverse smoking, and the next one is the erythroplakia. Okay, red is always dangerous. Erythroplakia. Then only comes the OSMF and erythroleukoplakia and all. OSMF, it has like a malignant transformation rate of like 2 to 8%, and lichen planus and leukoplakia comparatively very less chances of malignant transformation, around like 3.5% or like 6.5 or 9.5% only. Okay, so remember that. Now, next question. A man with heavy occlusion has wedge-shaped defects near cervical region in premolars and molars. What is the diagnosis? Okay, is it abfraction or abrasion or erosion or attrition? What is the diagnosis? Okay, heavy occlusion, lots of load is going into the cervical region, and no mention of any external substance like toothbrush trauma or like horizontal toothbrushing, or nothing is mentioned. So we are going with option A, abfraction. Okay, so what do you mean by abfraction? It is the loss of tooth structure because of the occlusal stresses. Okay, so this it will create wedge-shaped defects like this. Okay, like B or C-shaped defects like this in the cervical region, mainly in the premolars and molar region. Because of the heavy occlusal forces, the stress, the tensile stress will be concentrated on this cervical region, which will cause the disruption in the chemical bonds of the enamel crystals, which will result in enamel crack, and it will get chipped off or chipped off easily. Okay, so that will result in something like abfraction like this. Okay, so these are the wedge-shaped defects that are seen here. Okay. Now, next question. A female child patient came with brownish discoloration of teeth. On examination, enamel appeared normal, but easily gets chipped off. On radiographic examination, obliteration of pulp chambers and canals seen. She informed that her brothers also have the same condition. What is the diagnosis? Okay. So one thing we need to notice is that the brownish discoloration of teeth, enamel appeared normal, obliteration of pulp chambers and canals, and she also informed that her brothers also have the same condition. Okay, so we can guess that it is some kind of a hereditary condition. Okay, so since it is some kind of a hereditary condition, we can rule out option C and option D. Okay, then the remaining options are Amelogenesis imperfecta and Dentinogenesis imperfecta. Among these options, it is mentioned, if you look at it, it is mentioned in the question that the enamel appears normal, but it gets easily chipped off. Okay. So this, along with this obliteration of pulp chambers and brownish discoloration of teeth, is all the feature of Dentinogenesis imperfecta only. Okay, so in this Dentinogenesis imperfecta, you will be able to see brownish discolored teeth like this. Chipping away of the enamel from the dentine will be seen, and you see these radiographs, no pulp chambers will be seen here. Okay, the pulp chambers are completely blocked. Okay, so these all features point towards Dentinogenesis imperfecta. Okay, which is caused due to, it is a hereditary disorder of dentine, which is caused due to mutation in DSPP gene, that is the dentine silophosphoprotein gene. And it will like I had already mentioned about the findings that you see in the Dentinogenesis imperfecta. Okay. Now moving on to next question. A male patient with history of tobacco chewing presented with decreased mouth opening. No ulcers seen on intraoral examination. What can be the reason for reduced mouth opening? Okay, so out of the 4 options given, reduced mouth opening is usually seen in option A and option B. Okay, in lichen planus and leukoplakia, you will not see any symptoms of reduced mouth opening. Okay, so it is most commonly seen in a malignancy or in case of a osteoma. Okay, but it is specifically mentioned that there is no ulceration seen in the intraoral cavity. Okay, that rules out malignancy. And because of tobacco chewing, okay, which contains like the products of the tobacco chewing, it can cause this osteoma or oral submucous fibrosis, which is a potentially malignant oral disorder, which is mainly caused due to betel quid and all its related products. Sometimes like marble-like pallor of the mucosa, the submucosal bands can be palpated, the hockey stick uvula are all features of this oral submucous fibrosis. We had already discussed it in our classes. And the trismus can be like very severe that you can't open the mouth more than 20 millimeter. Okay, so that can also be seen. Okay, so that is the like the main diagnostic feature of osteoma also, along with the marble colored pallor of the oral mucosa. Now, next question. A female patient on routine radiographic examination showed a unilocular radiolucency between the mandibular premolar roots. The teeth are asymptomatic and vital. What is the diagnosis? So there were like 4 odontogenic cysts given. I remember only the 3. No impacted teeth. They not mentioned anything about the impacted teeth or anything. So that we can rule out the dentigenesis. And the teeth are asymptomatic and vital also. Okay, so we can rule out the radicular cyst also. And if you look at it, lateral periodontal cyst, the common location of this lateral periodontal cyst is this mandibular premolar region only between the 2 roots. So we can easily choose lateral periodontal cyst. Okay. Now, next question. Tramline calcifications are seen. Okay, direct, straightforward question. There's tramline calcifications. Where will you see this tramline calcifications? Yes, you will see it in Sturge-Weber syndrome. Yes. So the Sturge-Weber syndrome, it is also called as encephalotrigeminal angiomatosis or Sturge-Weber angiomatosis. What happens is that there will be like vascular proliferation, a hematomatous vascular proliferation will be happening in the brain and face. So that will result in like a pinkish, reddish to pinkish colored stain like this on one side of the face. Okay. Usually it affects the trigeminal nerve and its branches. So wherever the trigeminal nerve is getting supplied, it will show stains like this. Okay, reddish or pinkish stains like this will be seen in the skin. And these are called as port wine stain or nevus flammeus. Okay, this is called as the nevus flammeus of the Sturge-Weber syndrome. Intraorally, also unilaterally, you can see reddish stains like this in the palatal region. And one characteristic finding that you will see in the skull region is the tramline calcifications like this. Okay, so the tramline calcifications, the tramlines, I think you are all familiar with the tramlines. So you'll be able to see this tramline calcifications like this, see in the skull radiographs. Now, next question. A patient has a hard swelling in the floor of the mouth. It is painful and increases in size after eating. Radiographic examination showed radio-opaque mass. What can be the diagnosis? Another easy question. It is in the floor of the mouth. So something related to the salivary glands. Androlith is like a stone that is found in the antrum or in the sinus. Okay. And the rhinolith is the calcified mass that is present in the nasal cavity. Okay, so that is both of them are ruled out. Then we have the sialometaplasia. Okay, sialometaplasia will not produce a radio-opaque mass in the radiograph. So that is also ruled out, and the remaining option is sialolith, which satisfies the symptoms that the patient is having: heart swelling, painful, and increase in size after eating because of the saliva production. And radiographically, it will show a radio opaque mass like this also. Okay, so most common site for the sialolith is the submandibular gland only. The Wharton's duct is most commonly affected. So that's about the sialolith. Now, next question. Kuttner tumor refers to. Okay, what does Kuttner tumor refers to? Is it chronic sclerosing sialadenitis of submandibular gland, or myoepithelioma, or lymphoepithelioma of submandibular gland? Okay, Kuttner tumor, it is a easy one, straightforward. Okay, chronic sclerosing sialadenitis of submandibular gland. Okay, so this chronic sclerosing sialadenitis means it is a benign inflammatory condition, okay, of the submandibular gland, and it mimics like a neoplasm. Okay, it is not actually a neoplasm, but it mimics like a neoplasm. And histopathologically, you will be able to see something like this. Okay, lots of inflammatory cells will be seen. The acina units will be like very small and atrophied in nature. And in between these acini, you will be able to see sclerosed areas. Okay, because of the increased fibrosis, you will be able to see sclerosed areas like this in between the acina units. Okay, so that is the histopathological picture of this chronic sclerosing sialadenitis. And it is also called as Kuttner tumor. And this kind of appearance or this sclerosing sialadenitis you'll be usually seeing in the IgG4 related disease, which was also called previously, it was also called as Mikulicz disease or Mikulicz syndrome. Okay, so that's where you'll be seeing this Kuttner tumor or this chronic sclerosing sialadenitis feature. Next question. A 13-year-old male patient presented with a swelling in the mandibular area. Radiographic examination showed parallel rows of bone over the cortex buccali. What is the diagnosis? Parallel rows of bone over the cortex buccali. That is the key point here. So what they are referring to is the onion skin appearance in Garre's osteomyelitis. Okay, so the answer is option A, Garre's osteomyelitis, which is also called as proliferative periostitis. Okay, so it is formed as a result of a periosteal reaction to inflammation. This inflammation can be from dental caries because of a periapical infection, or because of a periodontal infection, or because of some kind of fracture or non-odontogenic infection. Any of that can lead to such periosteal reaction. Okay, so in the Garre's osteomyelitis, this typical onion skin appearance is here. That is like laminations of the bone deposition is like clearly seen, which gives the appearance of like onion skin reduplication of the cortical plate is commonly seen. Okay, and it is more common in children and young adults. Okay, around the mean age of 13 years also. If you look at the other options, that is acute and chronic separative osteomyelitis and all, we'll be able to usually see an ill-defined radiolucency in the radiogram. Okay, so we can clearly choose it is Garre's osteomyelitis. The next question, a 50-year-old patient reported with swelling in the oral cavity and radiographic examination showed sunburst appearance. Very straightforward question. The only key point that you have to look here is the sunburst appearance, and you can choose the answer without any further thinking. Okay, so the sunburst appearance is usually seen in osteosarcoma. Okay, so osteosarcoma is the most common malignancy to originate in the bones. The typical sunburst appearance is seen in osteosarcoma, then Codman's triangle, spiking root resorption. That are all features of osteosarcoma. Other than osteosarcoma, sometimes chondrosarcoma and melanotic neuroectodermal tumor of infancy. Okay, both these lesions can also show sunburst appearance, but these lesions are not given in the options. So we can rule out all the other options and choose osteosarcoma directly. And osteoblastoma and the fibrosarcoma, it may show like radiolucency with patchy areas of mineralization on. Okay, so such sunburst appearance is mainly from osteosarcoma. The next question, a common benign growth in gingiva is, Okay, is it melanoma, lymphoma, or papilloma, or squamous cell carcinoma? Okay, so in this question, melanoma is a malignancy of melanocytic cells, melanocytes. Okay, so we can rule out it is a malignancy. Okay, it is specifically mentioned a common benign growth. Okay, so we can rule out melanoma. Lymphoma is also a malignancy of the lymphoid system. Okay, we can rule out the lymphoma also. Squamous cell carcinoma is a malignancy of the squamous cell cells. So we can rule out the squamous cell carcinoma also. And the remaining option is only papilloma. So papilloma is a benign lesion which is commonly seen in the gingiva and in the palate also. Okay, it produces usually cauliflower-shaped lesions like this. Okay, so these are the cauliflower-shaped lesions that are seen in the gingiva and in the palate for this papilloma. Okay, so why these lesions are causing? Because it is mainly due to an virus. Mainly the HPV type 6 and type 11 viruses cause this kind of lesions in the oral cavity. Okay, so human papilloma virus lesions are many in number, like molluscum contagiosum, warts, and all are there. And one of such lesion is this squamous papilloma. So this it can occur in the gingiva also and appear like a cauliflower-shaped lesions like this. Okay. The next is a patient reported with swelling in the oral cavity. Histological examination showed numerous lymphocytes with macrophages between them, giving a starry sky appearance. Which gene mutation is involved in it? Okay, very interesting question. So first we need to identify the pathology. Okay, so the pathology which gives the starry sky appearance is Burkitt lymphoma. Okay, which is also called as African Joe lymphoma. Okay, so it is a malignancy of B lymphocytes, which Epstein-Barr virus is also involved in it. And the clinically, it usually occurs in children, mainly in the maxillary jaws. And one of the typical features of this Burkitt lymphoma is its histopathological feature. There will be like sea of lymphocytes, and in between the sea of lymphocytes, like here and there will be macrophages seen. Okay, so these macrophages and lymphocytes, it will together give an appearance of the starry sky appearance. Okay, so the lesion or the pathology they were mentioning in the question is about the Burkitt lymphoma. And in the Burkitt lymphoma, there will be translocation happening in this region, which will lead to overexpression of c-Myc. Okay, so this Myc is kind of like a proto-oncogene. Okay, so any mutation or any overexpression of this Myc gene, it will lead to formation of the tumor. Okay, in this case, it is leading to the formation of Burkitt's lymphoma. Okay, so that's about Burkitt's lymphoma. Now, next question, we are coming to syndromes. Okay, so let's look at the syndromes here. A patient has syndrome characterized by features showing cleft palate, glossoptosis, and bird-like faces. What is the diagnosis? Cleft palate, glossoptosis, and bird-like faces. Actually, they had missed out one more feature, which is the micrognathia. Okay, which is usually seen in the Perry-Robin syndrome. So the Perry-Robin syndrome is like described by the triad of cleft palate and mandibular micrognathia and glossoptosis. Okay, so this will result in a bird-like faces like this for the patient. Okay, so Perry-Robin syndrome, it is also called as Perry-Robin sequence or Perry-Robin anomalad. Okay, so what do you mean by anomalad? Anomalad means one anomaly is leading to or progressing to another anomalies. Okay, so first thing what is happening in this Perry-Robin syndrome or Perry-Robin anomaly is that there is deficient progress like development of mandible. Okay, so since there is deficient development of mandible, it will result in mandibular micrognathia. So during the development process, the tongue will not be able to come down to this mandibular region. Okay, so that will result in like a large tongue or like glossoptosis can occur And so the tongue stays in the upper part of the palate itself. So the palatal shelves cannot be closed. So it will result in something like a cleft palate, which is like perfectly U-shaped in case of a Perry-Robin syndrome. Okay, such perfectly U-shaped clefts are not usually seen in the cleft palate alone cases. Okay, so because the tongue is not able to come down to the mandibular area or to the floor of the mouth region, it stays in the upper region and it will form a cleft in the palatal region. So that will result in a cleft palate. Okay, so these are the main three characteristic features that you see in Perry-Robin syndrome. Okay, Perry-Robin syndrome and Perry-Romberg syndrome. Okay, they sound similar, but these are two entirely different things. This Perry-Romberg syndrome is hemifacial atrophy. Okay, progressive hemifacial atrophy, where you will be seeing like one side of the face, all the structures on one side of the face will be small or atrophied in nature. Okay, there only in this Perry-Romberg syndrome only you'll be see the coupe de sabre and the strike of the sword and all that and all you'll be seeing in this Perry-Romberg syndrome on. Okay, this is the answer for this question is Perry-Robin syndrome. Now, next syndrome question. Cry-du-Chat syndrome is due to mutation of which of the following? Okay, so this Cry-du-Chat syndrome is due to mutation of 5p. Okay, so there will be deletion of the short arm of the chromosome 5. Short arm in a chromosome, there will be two arms. One is P arm and other one is a Q arm. And if this is a chromosome, there will be two P arms and two Q arms will be there. P arm is the short arm and Q arm is the long arm. Okay, so when there is deletion of the short arm of this chromosome number 5, it will result in Cry-du-Chat syndrome, which is also called as cat cry syndrome also, because the child will produce like a high-pitched crying, like the cry of the cat. Okay, so that's why it's also called as cat cry syndrome. And the chromosome that is involved is 5p. Deletion of 5p happens. Okay, and all the other features will be there, like small head, hypertelorism, very deeply growth philtrum, small chin, low set ears, and edematous feet and hands will be there. All those features will also be seen in Cry-du-Chat syndrome. Next question. A syndrome with non-tender labial enlargement, plicated tongue, and recurrent facial paralysis is which of the following syndromes? Okay, there will be like labial enlargement will be seen, and plicated tongue. Plicated tongue means they are referring to like fisher tongue or scrotal tongue, like that only they are referring. And recurrent facial paralysis is also there. Okay, so this is the characteristic triad of Melkersson-Rosenthal syndrome. Okay, so in the Melkersson-Rosenthal syndrome, you'll be able to see swelling of the lips and face like this, which will be more similar to like orofacial granulomatosis. Okay, then it will be non-tender. Just the swelling in the labial region will be usually seen. Facial paralysis can be seen and fisher tongue like this, which can be also be seen. But the word they used in the question is not fisher tongue. That will be too much straightforward. So they had used the word as plicated tongue. Okay, so this is what plicated tongue or fisher tongue refers to. Okay. So I think that's all the questions that had appeared in oral pathology and oral medicine for the NEET MDS 2025 examination. If you remember some other questions, like I think there was a question on like in the options, there was like a Hurler syndrome given. And in the question, there was something like a loss of crypt or something like that was given. So if you remember that question or if you remember any other question, then you can comment under this video below. Okay, it will be very useful for the next batch students and for us also. So if you remember any other questions, you can comment under the video below. Okay. Okay. So all the best for the ones who are going to write the examination in the 2026. I think you got a general idea about how the questions were asked for the NEET MDS examination. I think you got a general idea about it. That's very important. And all the best for your preparations. Do well. Okay, and for the ones who had already completed the examination, don't worry about the results and answers now. We will come to it when the results come. Okay, so don't worry, start worrying now itself. Okay, so all the best for your future endeavors. Do well. Okay, good night. Bye.